Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. By the time we reach adulthood, most of us have experienced a little heartburn, right? That unpleasant burning sensation in the chest might wake us up after eating spicy foods, for example. It's treatable and goes away, but for about 20 out of every 100 Americans, heartburn is actually a symptom of a chronic condition called gastroesophageal reflux disease, or GERD. Persistent heartburn, difficulty swallowing, a chronic cough, even chest pain can all be symptoms of GERD that impact your quality of life. But recent studies now link GERD to other conditions like tinnitus, asthma, even cancer. MedStar Health gastroenterologist Dr. Vinshi Khan is here today to talk about GERD and the importance of treating it. I'm your host, Deborah Schindler. Dr. Khan, thanks for being with us today on MedStar Health Doc Talk.
Thank you, Deborah. Thank you for having me.
Dr. Khan, the symptoms of gastroesophageal reflux disease could be dismissed for heartburn or even acid reflux disease. The terms seem to be interchangeable with GERD. How are they different? Are the symptoms different?
So GERD is like the pathological entity, which is a chronic GI condition where it is characterized by the retrograde flow of stomach contents into the esophagus, or the regurgitation of the stomach contents into the esophagus. So that's the pathological definition. The disease entity is called gastroesophageal reflux disease, and heartburn is the most common sign or the symptom of this entity. So yes, sometimes patients use it interchangeably, but it is not the only symptom of this disease and should not be used interchangeably.
Acid reflux disease is actually the same thing as GERD. It's the process of the regurgitation.
Yes.
And then the heartburn is the symptom. Is the
most common symptom. And there are other symptoms that can be seen with this condition, like chest pain, difficulty swallowing, cough, and so on. So it is heartburn is the most common symptom of it, and sometimes it's used as a layman terms of describing this disease.
Now, I guess that heartburn is the most predominant symptom of GERD. Do you have to wait to have it a certain amount of days a week to experience frequency to be able to say, hey, I think I have GERD?
The rule of thumb is when anything is occurring to a point that it is affecting your quality of life, where you have to take a step back or maybe look for over-the-counter medications quite often, I would say that's the time to seek expert care. Go at least discuss it with your primary care doctor. It is a physiological response to eating, the reflux. If I were to have a late dinner, I would have some acid reflux. So I can expect that. But when, despite in my regular day-to-day life, if I'm having it more so often and it is affecting my quality of life, then that is something that needs to be addressed.
Why would a late dinner be more of a problem for GERD?
So, it depends on the fact that the gastric emptying, the stomach has to empty ideally should be empty before you go to bed to avoid the risk of acid reflux. So people who have late dinner tend to not have that enough time for the stomach to empty properly and before going to bed. And right now, you and me sitting upright, the gravity is helping us in terms of preventing reflux. Mm-hmm. But when we eliminate the gravity and we go to bed, and if our stomach is full, that increases our chance of reflux. I ideally tell my patients to have a gap of at least 3 hours, ideally 4 hours between the supper and the bedtime.
A whole meal. What about a snack? Because I'm good for having snacks before I go to bed.
That's another, snacking, late night snacking will also cause acid reflux. That's I'm going to be honest, a lot of my patients tell that, hey, I take my dinner at this time, but then when I dig into it, they fess up and say that, oh, I do have late night snacks. And that is the reason and the trigger for their acid reflux.
I mean, I admit that we have dinner late very often because we get home late from work.
Yep. Yeah. Sometimes like people are on night schedules and different schedules. Sometimes life is busy. So yes, it is a difficult thing to maintain, but that's one of the recommendations that helps, if followed consistently, does help your reflux symptoms.
Well, how does it not stay down in the stomach? Is something happening, something changing in the body for it to come up?
Like, it is a process of accommodation. Like, when you eat, you're obviously taking into air as well. And there has to be some relaxation, like some way of venting the air out. Some people belch, some so it is more of a way of like removing extra air from the stomach.
I think I was expecting some explanation about that sphincter. Isn't there a sphincter muscle that doesn't stay closed?
Yeah. So, yes, there is we have some protective mechanisms naturally in our body to help protect us from reflux. We have what is called an upper esophageal sphincter and a lower esophageal sphincter. Lower esophageal sphincter is the sphincter between the esophagus, the food pipe, and the stomach that helps against these episodes of reflux. But sometimes the stomach has to, what is called gastric accommodation. It has to release the pressure. And sometimes in doing so, in releasing the air, there is a reflux of gastric contents as well. And sometimes some patients they're obese or they're pregnant. There is more abdominal pressure on the stomach. So the esophageal sphincter kind of gives away or like is weak in those cases and is overwhelmed. And also like if you're older patients, there is a disruption of the muscle integrity. So they are more prone to have acid reflux. So these are some of the factors that kind of may overwhelm the esophageal sphincter. Sometimes you have what is called hiatal hernia, where a part of the stomach kind of goes up and down into the chest, and that also disrupts your esophageal sphincter. So these are few things. We do have some like natural mechanisms of protection, but then we also have conditions that can overwhelm it.
So some of the risk factors then are diet, obesity. You mentioned the hiatal hernia. Smoking certain medications can cause GERD?
Yes. So like I always say that I kind of divide the risk factors into like lifestyle, medical conditions, medications, old age, and then other environmental factors. Lifestyle would be obesity. If you're obese, if the way your eating habits, if you have late dinners or if you have like more fatty, greasy foods, especially in dinner, or you're a smoker. So these are lifestyle risk factors for acid reflux. Or you drink alcohol quite heavily, especially in the evenings and stuff. So those are the lifestyle risk factors. In terms of medical conditions, pregnancy causes it. Hiatal hernia, as I mentioned, that it is the part of the stomach that goes up into the chest from the abdomen. That also increases your risk of acid reflux. Then there are conditions called gastroparesis, which is mostly seen in diabetic patients where the stomach is paralyzed and it doesn't move so well. So the food sits in the stomach longer than the usual periods of time, and that causes more acid reflux. So those are certain medical conditions. Then it comes to like medications, certain medications, especially the ones that we take for like aches and pains like Aleve, Motrin, ibuprofen, Excedrin, which all come under what is called NSAIDs, which is non-steroidal anti-inflammatory medications. They also increase your risk of acid reflux. Certain blood pressure medications like calcium channel blockers like amlodipine and so on, they can also increase your risk by relaxing the esophageal sphincter. Then it comes to old age. Old age, just by the virtue of aging, you kind of lose the muscle integrity or like the esophageal, there is some age-related disruption of the esophageal sphincter. So that can happen. Other factors being stress, sleep deprivation, anxiety. Those are also factors that puts you at risk of acid reflux.
Should someone see a gastroenterologist specifically for GERD, or can they see their primary care physician and expect appropriate treatment? Or would they just be referred then to a GI doctor?
So I believe for most of the patients, almost all of the patients, the first point of contact to express these concerns and discuss would be their primary care doctor. And the primary care doctors, most of the treatment is for acid reflux is a trial of antacid. Okay, so that can very well be addressed by the primary care doctor. And if at that point, it all depends on like the comfort level of the primary care doctor. If they feel like, okay, this is happening so often, you're having other symptoms like trouble swallowing or stuff, you need to be referred. Or sometimes they say that, hey, it improved with this trial of this medicine. You just need to do these lifestyle changes and let us see if it worsens or keeps on happening. At that point, they would refer. But yes, most of the times, I think the primary care doctors can address it to certain, like the mild cases of it. And any point that they don't feel comfortable, they are happy to refer it to us.
What are some of those medications like Mylanta, Tums, Pepto-Bismol?
So there are like different categories. They all kind of come under antacids, okay? So the usual antacids are like the neutralizing medications like Tums, Mylanta. So those are milk of magnesia and things like that. Those are the antacids, which are actually just literally neutralizing agent. They neutralize the acid. Then there are other medications, which are H2 blockers, which famotidine, Pepcid, which are over the counter. They are those. And then the ones that are most commonly used are proton pump inhibitors like omeprazole or Nexium, those common ones which are now even available over the counter. And then we have a new class of medications which are called PCABs, which are potassium competitive acid blockers, which was only in 2023 approved to be used in the US. We have only one drug that's available. So that's also one of the new upcoming option for treatment.
And you wouldn't prescribe any of those without an actual diagnosis. So let's get to that part. I feel like we might have jumped ahead a little bit, but a patient comes to you and they've laid out all of their symptoms and you start to suspect that they have gastroesophageal reflux disease. Mm-hmm. What's the first step in getting a proper diagnosis?
So the first step is to listen to the patient, see what they have to say and how they present their symptoms and how frequent are the symptoms. Are there any associated symptoms? Trouble swallowing, nausea, vomiting, epigastric pain or upper abdominal pain, and cough. They may have gone to a lung doctor or their other doctors for cough that was or an ENT even doctor to see for their cough, but then they were referred to us because of cough. So anytime, it depends on the frequency of their symptoms, and then if there are any red flag signs like trouble swallowing and so on, at that point we have to at least start them on the treatment like medications. Sometimes for the mild cases we can just start them on medication and see how things are going. Usually when it has been a chronic issue and there are some other red flag signs, we would want to proceed, especially if they are older, we would want to proceed with an upper endoscopy, which is esophagogastroduodenoscopy, which is a flexible tube with a camera at the end. We go down your mouth and look inside the stomach and esophagus to look for any changes from these reflux symptoms.
Are the patients at that point under general sedation, or are they in a twilight?
For EGD or upper endoscopy, we usually use twilight or a conscious sedation, which is a twilight sleep, and they are still breathing on their own, but they're just comfortable. They're not gagging, and they can tolerate the procedure.
What's an esophageal manometry?
Esophageal manometry for patients who have trouble swallowing, which is called dysphagia, whether it is to solids or liquids or both, we do a procedure called manometry, which is basically they put a probe down your nose and then they ask you to swallow different consistency foods like liquid, like water, nectar thin, nectar thick, solids, and then they see how the esophagus is contracting, and then they generate a report, send it to the doctor for interpretation, and that helps us identify what is the cause for the trouble swallowing. So manometry is usually for trouble swallowing. Sometimes we can couple it with what is called pH monitoring to help also identify acid reflux symptoms during these episodes. So those are slightly two different kind of tests. Manometry is for to see the muscle contraction of the esophagus. And Bravo study or pH monitoring is to see how much correlation are we having with your symptoms versus an actual reflux event at that time. So those are the things when someone has had acid reflux, we have tried them with the regular medications and they have not had good relief with it. And we have increased the doses and they're still not having much relief as expected. And the upper endoscopy has not been, doesn't show severe changes or any hiatal hernia or any factors that may increase their risk of having persistent acid reflux. So at those points, we do what is called pH monitoring or a Bravo study to look for these reflux events in real time and see how much of the actual reflux event correlates with their symptoms.
Did you call it a Bravo? Okay. And how do you do the pH monitoring? How is that performed?
So it's with a Bravo capsule, which is earlier there were probes that would stay inside the patient through the nose. They would go home with a machine and bring back the machine with instructions that, hey, when you're eating, you need to click the buttons. And when you have an event of acid reflux, you click the buttons and so on to record your events. It's better now in a sense that we do an upper endoscopy and we deploy the Bravo capsule into about 5 to 6 centimeter above the stomach. We kind of deploy the capsule and it gets fixed to the esophagus. And then we send them with a wireless device and tell them the instructions how to use it and say, hey, you need to record when you're eating and then when you're sleeping and then whenever you have symptoms. And then they bring out the machine back to us in 48 hours. And then we generate a report and then we see how much correlation is there between their symptoms versus an actual reflux event that was recorded by the machine.
Can they feel that when it's in there for 2 days?
So it's a very tiny capsule receptor kind of device. And they don't feel it. It doesn't cause any trouble swallowing. We have had practically no one complain of any pain or any trouble swallowing. And it kind of sloughs off by itself in a few days. And sometimes people may see in their poop. Sometimes they may not even notice it. So they don't have to bring back the device that in the esophagus. They just have to bring the wireless device that they go home with.
And how does that device get the information from the capsule? I'm a little confused about that.
So it's a wireless device and it's programmed to connect get
Wi-Fi.
It's Wi-Fi, and it kind of communicates. It has to be within a certain vicinity of the device, so you have to keep it close to you. The device, which is in the esophagus, is monitoring for reflux, and the device what you're using, you are manually putting in your eating time.
4 o'clock, I'm having dinner.
Yeah, dinner. 4 o'clock, okay. So you're manually putting your sleeping time, your eating time, and your reflux, your heartburn or reflux symptoms in there. But the device in your esophagus is monitoring the actual reflux events.
I should have said 10 p.m. eating a sub. That would be more realistic for me. So the treatment varieties, let's go through the current treatment options. We talked about the lifestyle modifications. We talked about medications. And I do understand that you're not the surgeon in a case. You would refer a patient who needed surgery to a surgeon. When would a patient need surgery? What would you find? What would be the results of their screenings or your tests?
So all of those patients where we are at the point that we may consider surgery have had an upper endoscopy and we kind of know their anatomy. So patients who have had chronic symptoms, chronic debilitating symptoms, which is affecting their quality of life, they have been on maxed out medical, they have been medically optimized to the max in a sense that they have been on twice a day and medications. And sometimes we may even have to add another, they're on omeprazole twice a day. And then we also have to add famotidine or something at bedtime. So if they are still not well controlled on max medical management, it's affecting their quality of life. And then if they have any anatomical conditions like hiatal hernia, those are the conditions that help us. At that point, we have to, like, if they have a large hiatal hernia, it's affecting them to a point that they are willing to, like, ask about the next steps. That's when we address and say that, hey, there are other options like endoscopic and other surgical options that we have.
I know I won't ask you to explain them, but I would like for you to name them. There's 4 surgical options or procedural options that any listener who thinks that they may need that could ask about.
So the ones that I feel are the ones that I would send my patients for, like there are few. So there is one which is called Nissen's fundoplication, which is usually in patients who have a hiatal hernia, which is usually greater than 3 or 4 centimeter. The surgeons have to do it, and they basically create a wrap of the stomach around the esophagus to reinforce the sphincter. So that's that. That's the Nissen fundoplication. Then there is a Lynx procedure, which I rarely use it or suggest it to my patients because of the side effects that can happen or complications that it may lead to. It's basically the surgeons place a magnetic ring to reinforce the sphincter, or patients who have hiatal hernia, it reinforces the sphincter in those patients. I don't like it because some people, there is migration of the ring and it can cause trouble swallowing or inflammation in the esophagus from the pressure. And then the other one, which we can do like endoscopically, which is like less invasive than a surgery, is called TIF, which is transoral incisionless fundoplication, which a gastroenterologist can do it, but there are certain conditions to it that the hiatal hernia has to be 2 or 3 centimeter max, and it's not a 360 wrap, it's a 270-degree wrap. So those are the things, but that's one thing that it doesn't require a cut or a major surgery.
What about TESS, transcutaneous electrical stimulation system? Is that performed routinely?
I have never sent someone for it.
Interesting.
And I think it's really not used nowadays. It is to kind of reinforce the sphincter with the electrical stimulation. But I feel like it's really
maybe it's phased
kind
out.
of like phased out and obsolete.
Mm-hmm. But these are generally minimally invasive procedures.
Minimally invasive.
Outpatient.
Nissen's fundoplication is the most invasive, I would say, but it's still like done laparoscopically.
And they go home the same day?
Usually, and if depending on, they may have to stay a day, but at least for the endoscopic procedures, they go the same day. It's an outpatient procedure.
I found that interesting too when I was reading some material on GERD to research for this podcast. Some emerging treatment options. And I'd like to get your thoughts on the research being done. Do you have any comment on drug developments targeting esophageal motility and acid secretion?
So like I mentioned earlier, the most recent one is what is called PCAB, which is potassium competitive acid blocker, which is like a prescription medicine. Vonoprazone is the brand name, and it has only approved in the U.S. in 2023. That is one of the novel medications that is out there. We have not really started using it that much, but I'm reserving it for patients who have not had good response to PPI or proton pump inhibitors like omeprazole or pantoprazole, and or they have like contraindications to that, like osteoporosis and kidney problems and so on. So those are those. And
it sounds to me though that would not prevent the regurgitation. It would only stop it from being so acidic. Or am I misunderstanding that?
So in a way, I would say that the reflux would happen, especially if you're like going to sleep or things like that. But it helps protect the integrity of the stomach and the esophagus from the acidic contents of the stomach. So those, it's not going to reduce the reflux events, but it helps to reduce the damage that it would produce.
Okay, true or false? Let's do a little myth busting. I'm going to ask you a couple common perceptions, and you can tell me if they're true or false. Milk soothes the symptoms of acid reflux. Do you recommend milk for people who suffer?
No.
Heartburn or GERD?
No. If it was just a low fat or like fat-free milk, maybe it can act as a buffer, but usually the full fat milk is not going to help you. It may even worsen your GERD symptoms.
Okay, high acid foods worsen the effects of GERD.
Yes.
True.
That's why we ask you to, like, whenever we say about lifestyle and eating changes, we ask you to avoid highly acidic foods like citrus foods like orange, lemon, and so on.
Mexican. That's pretty spicy, the Mexican food.
The spicy foods, yes.
The kids love it.
Yeah, peppers and stuff.
Intermittent fasting is good for gut health and therefore helps those who suffer with GERD.
Yes, intermittent fasting is any of my patients who are obese or overweight and want to start like something that would kickstart the weight loss. I suggest intermittent fasting. When you start the intermittent fasting, our body goes into what is called autophagy, which is basically it kinds of devours anything that it's like a cleaning shop process in the body. It destroys the damaged cells of the body, anything that was probably mutated or something. So its research has shown that it has anti-cancer properties in the sense that it helps prevent cancers, or it may help reduce progression towards certain kind of cancers by causing autophagy. So intermittent fasting is good. Yes and no. Intermittent fasting helps. In overall, I would say it helps with acid reflux. It reduces acid reflux, but not so much in patients who have severe acid reflux symptoms or have anatomical conditions like a large hiatal hernia. They may not see much reduction in their acid reflux symptoms due to anatomical cases. Intermittent fasting increases what is called ghrelin. It's a hormone in our body, and ghrelin is inversely proportional, like has an inverse relation with acid reflux. So intermittent fasting helps with that. The other thing is intermittent fasting reduces the insulin resistance in our body. And insulin resistance causes weight loss. Decrease in the insulin resistance leads to weight loss, and weight loss overall helps with reducing acid reflux. So I would say, yes, intermittent fasting overall helps in reduction of acid reflux. Yes.
All right, one more, true or false. Only overweight people get GERD.
False. Anyone, even a person thin as stick, can get acid reflux because either they are pregnant or they are taking medications or they are stressed out or they don't have the best eating habits. So it's not just not reserved for obese patients.
A very common misconception, though.
Yes.
Can you get stomach ulcers from having GERD? Are they related?
No,
Not really.
Stomach. You can get ulcers in the esophagus or what is called erosive esophagitis, which is a severe case of GERD, acid reflux or GERD, but not so much stomach ulcers.
I was just going to ask you about erosive esophagitis. It sounds horrible. That sounds like it would be really excruciating.
Yes.
What is that exactly?
So erosive esophagitis is the severe form of GERD. So GERD is an umbrella term, and it includes what is called non-erosive reflux disease, which is about 70% of the patients where you do an endoscopy. They do have the symptoms, but they don't have like inflammation that we can see in the esophagus. So that's non-erosive acid reflux or reflux disease. Then certain patients, I would say 20% or so, 20 to 30% can have what is called erosive esophagitis, which is basically disruption of the epithelial integrity of the esophagus, meaning the lining of the esophagus is disrupted, is ulcerated, and is inflamed. And some people say Barrett's esophagus is also a precancerous form of acid reflux or GERD, which would be a complication and a long-term risk of acid reflux.
That is where we then enter into the risks of cancer.
Yes.
Esophageal cancer.
So the reason we want to be aggressive in treating acid reflux, because it does have, it can cause long-term sequelae or complications. Like some of them are like a stricture, meaning there is a scar. Because of all these inflammation and so on over the years, there's a scarring in your esophagus, and it has formed a stricture, like a bottleneck in your esophagus where the food is getting stuck. So that requires like kind of multiple dilations, stretching of your esophagus, and still may not be very effective. You may still get food stuck in your esophagus. Then what is another long-term complications of acid reflux is Barrett's, which is a precancerous change in the lining of your esophagus from years and years of acid exposure. The stomach has a high acidic environment, and the stomach wall is like designed in a way that it is equipped to handle that kind of acidic environment. But the esophagus has a different kind of lining, which is not used to that kind of acidic environment. But over the years, if you have like so much exposure of the acid, the esophagus is kind of forced to change to a stomach lining so that it can withstand that kind of acidic environment. So that change in the lining from the original lining of the esophagus is called Barrett's. And there are certain steps, like, it's basically what is called metaplasia. I don't know if I can put it in a layman term, is basically
where the cells change from a regular lining, from a normal lining. So this is a normal lining. The next step is a metaplasia. The next step is a dysplasia. And the last step is neoplasia. Neoplasia meaning cancer, malignancy. Mm-hmm. So these are the meta, the dys, and the neo. So these are the steps before the cancer. So the Barrett's is basically metaplasia, which is few steps before cancer. Do you ever see that when you're doing an endoscopic screening on someone?
Yes.
Just automatic, wow.
Yes, it's quite common, especially in men who are smokers. It's common.
And they've just ignored the signs for a long time.
Yes. Or maybe some people, they don't have that degree of heartburn or symptoms, but then as they age, they get more and more symptomatic is when they seek the care. And at that point, we see those changes already.
In the intro, I mentioned that there have been medical studies that have shown GERD to have an association to other conditions. Some I just didn't think would be associated with GERD, such as tinnitus. How do you explain that? Tinnitus, let's explain what that is first.
Tinnitus is a ringing sensation in your ear.
That never stops.
So I would say it is rather rare, association with acid reflux. It is more so like when you have so much acid reflux that it is kind of into your throat, all the way into your ears, and it has irritated your middle ear.
What about asthma? How does it cause or relate to asthma and allergies?
In terms of asthma, especially like patients who have had good regimen of asthma medications and they're still not well controlled, or they have more like nighttime wheezings and stuff like that. In those patients, we worry about them having underlying acid reflux that may be contributing towards the asthma, and that may be the reason why the asthma is still not well controlled.
And cardiovascular risks.
Many patients come, especially women, they come in with heartburn symptoms and stuff like that. We have done all the workup and everything, and we found that, okay, they actually, they have reduced blood supply in their heart, and they are having more of atypical symptoms of, rather than like a full-blown chest pain sending you to the ER, they have more of these acid reflux symptoms, which later they found that, okay, there's a blockage in their coronaries or something like that.
Okay, so your final message for managing GERD. Give us the laundry list in making some lifestyle changes. That would be the first step. What's your advice?
Lifestyle modifications and dietary modifications are the mainstay of treatment of acid reflux, because we can try to put you on any medications, but if you don't follow that basic block of recommendations, you would still not have full relief. There's a lifestyle and then there's a diet change component to it. And for lifestyle, I say quit smoking, lose the weight, try not to have heavy meals at night, try to have a gap of at least 3 hours before the supper time and bedtime, avoid late night snackings and so on. Like alcohol, especially at late night, would be a problem as well. So those are the lifestyle part of it. In terms of dietary, I would say try to avoid fatty, greasy foods. Chocolate, I know it's a big problem for many of my patients, but chocolate, again, alcohol, Caffeine is the one. Energy drinks, carbonated drinks, soda, pop, they are all a lot of problems. Some people even have a lot of trouble with garlic, peppermint, and so on. So like everyone has like kind of by the time they see us, they have identified their triggers, and we tell them that, hey, these are the usual triggers, but then you have certain unique triggers. You should avoid them.
And night eating. That was a funny phrase even. I never heard night eating. So if you do night eat, would it help people to prop up when they sleep?
So like, yes, like elevation of bed, like head of the bed or like propping up yourself with two or three pillows is always helpful. But the best thing is to avoid a meal within 3 hours of eating, especially if you have a large hiatal hernia or so on. You may still want to prop yourself up at night, but I would still say elevating is one of the recommendations. The most important is to have a gap of 3 hours.
What's the worst case of reflux that you've ever seen?
I'm going to be honest. The worst case of reflux can be different ways. Like, there is what is called like esophagitis, erosive esophagitis, where there are different grades of esophagitis, where I would say LA, like Los Angeles, grade D is the worst kind of esophagitis you can see. It's basically the whole circumference of the esophagus is involved. That the worst case can be that, okay, there is esophagitis and I also see a stricture. Worst case can be that the patient has had all these years of undiagnosed acid reflux, now probably also had Barrett's for years, and now they have cancer. These are the sad scenarios we see.
So our final word on that would be, if you suspect that you have reflux disease,
seek medical attention.
Right.
Talk to your primary care doctor and see if they want to send you to a GI doctor. And we here at MedStar Health would be happy to see you.
Thank you, Dr. Khan, for sharing your valuable information with us about gastroesophageal reflux disease. That's Dr. Vinshi Khan, board certified in gastroenterology and internal medicine with MedStar Health.
Thank you, Deborah, for having me. It was a pleasure. Thank you.
Got through it. For more information about GERD, go to medstarhealth.org/GERD, GERD.